therapies, when they come into Canada, they need to go through various approval processes, right? And most of them basically require clinical trials. Is it like phase 3 clinical trials to be then subsequently widely accessible to patients? And real world evidence is not necessarily that it's not looked at, but it is not the primary driver for, let's say, access to therapy. So could you speak about how real world evidence can shape health services, and maybe where there's still additional opportunity for it to help shape health services as well?
Sure, that's right. And I think that's a great potential use of RWE that is really underutilized by regulators. So I'm actually going to give you three examples that sort of highlight kind of different aspects of this whole issue. So the first example I'm going to give you is understanding, or the first two is understanding how a treatment performs in the real world. So uh, when I first started my career, we had a drug, a targeted therapy, a drug called erlotinib that targeted, later we learned it targeted patients with EGFR mutant lung cancer. It targeted their cancer. But at the beginning, we thought it was good for everybody because we didn't have very good treatments for lung cancer. So it was a little bit better if you use this. And it didn't matter what kind of cancer, lung cancer you had. So that was approved. It was a big Canadian advance. It was used very widely. And then over time, when we discovered the EGFR mutation, most people gravitated towards using these targeted therapies for that. But then there was always this belief that, probably still does a little something in people who don't have the mutation. So we actually did a study. Dr. Kirsten Pertuzé, she's now an oncologist at William Osler. She's phenomenal. So she did the study and she used data, real world data, from ICIS or ICES, which is the provincial database on health outcomes of patients here in Ontario. And we also collaborated with Cancer Care Ontario. We got a list of everybody who'd had erlotinib in the province over a 5 to 10 year period. And we looked at patients who clearly didn't have the mutation. They were on the mutation, they were on the treatment for a very short period of time versus patients who clearly did. And in these databases, mutation status isn't so good. We need to work on that. But that, so we sort of looked at sort of, if you're only on it for a short period of time, is it still improving your outcome like the clinical trial said it would? And we found the reverse. We found that these people actually, if they never got erlotinib, they actually lived longer than these patients who clearly didn't have a mutation that got erlotinib. So that was interesting to us. And it kind of clearly reinforced this is something we shouldn't be giving to someone without mutations. Now, could you argue it's not a prospective randomized trial in this group of patients? Yes, you could. But in the US, this has lost its label. I think in Canada, if it hasn't lost its label yet, it's certainly gone out of use. But we think that we've provided some pretty good data for whom not to treat with these drugs. In Germany, they were using this. They'd abandoned it briefly, but I think they're going back to it, where if you approved a new drug, you could use the drug for a year. The company could market the drug. The German government would pay for the drug. Patients would use it. And at the end of the year, they would look at patient outcomes and they would compare it to the current standard or comparator. So let's say second line treatment, patients would give them docetaxel chemotherapy, which is kind of awful. And then you'd have this new treatment. And then they would look at, okay, how did people who got docetaxel do sort of in the recent past versus people who got this new drug? And based on how that drug performed, so let's say it was safer, people didn't go to hospital, people lived longer, well, that's good. So you could charge more. If it was worse, you had to charge less. And if it was about the same, you didn't, and you couldn't prove any clear advantage, then, potentially you'd have to price it the same. So that was a very interesting application of real world evidence. Now, the problem was they couldn't get the data in time. It was a real challenge, but they've really upped their game in terms of RWE, national database collection and centralization. And so, they're much more automated in real time. So I think they're actually going back to that system. So that is potentially very helpful in Canada, right? So, if there's a blockbuster drug, but we're not sure that it's really helpful, could use it for a year and see what happens to these patients. The third part of that story is, for example, in lung cancer, there are these small populations with targeted therapies. Nobody can do a randomized trial, or the companies won't. It takes too long. And we recently, for example, did a study in patients with RET fusion positive lung cancer. So we had great data, 80 or 90% response rates. People were on treatment for more than a year, amazing drugs. They would go to the brain and shrink brain tumors. Fantastic, right? In my opinion, clearly better than chemotherapy. The regulator said,
Mhm.
oh, you don't know how well chemotherapy does in this kind of lung cancer. You've shown us the overall data, but we don't know about this group of patients. So, in databases like Flatiron, and in this Canadian database, national database that's being put together, you can pull out all the RET positive patients and say, okay, this is how they did on treatment A, treatment B, treatment C. It's not perfect, but at least it's a type of benchmark, right? So you can say, okay, if you had the mutation versus if you didn't have, what's the difference? Do these patients really do better, or they all kind of do about the same and badly? And then the regulators can say, oh, okay, so just based on this, indirect comparison, this is how the new treatment does. So it does enable. Now we are not, as people who should be generating these data, we're not publishing it fast enough. We're not analyzing it fast enough. We're not producing it in a consumable fashion for the regulators, and we need to start doing that. So that's one thing. And then the regulators need to start using it. So instead, we had to do this huge randomized trial where the targeted therapy for RET just blew chemotherapy out of the water. And it was honestly ethically inappropriate to have let this study continue, right? Because we already had the data. Now, in fairness, chemo did work a little bit better than it does in people without the RET fusion, but nowhere near as well as the targeted therapy worked. And so then how do we go back and teach the regulators, okay, these are the thresholds. You don't need a randomized trial for this, this, and this, but maybe you need a randomized trial for these other things. And then we also teach the drug manufacturers and everybody else and the trialists so that we steer our resources correctly and we don't end up where, the FDA approves something on 20 patients, the rest of the world thinks that that's not very good, but the drug manufacturer won't go build more evidence because they got their US approval. If we could sort of have a
Yeah.
clear understanding what needs more research and truly what doesn't. This is gold, let's just switch. And I think the data are all there in RWE. We need to do a much better job of getting it into the hands of the regulators in a usable fashion.